Hello everyone, welcome to the second lecture on the series Parkinsonism and antiparkinsonian drugs. So in this lecture, we will be discussing drug targets of Parkinson's disease and the individual drugs. So the pharmacologic targets of Parkinson's disease are the peripheral dopa decarboxylase inhibitors like carbidopa and benzodiazepides, the dopamine precursor like levodopa, then dopamine agonist like bromocriptine, pergolide, pramipexole and ropinolone, or MAO-B inhibitors like seleginine, rasagiline, or COMT inhibitors like tolcapone, entacapone. Tolcapone acts in the CNS and entacapone and tolcapone both acts peripherally. So this is about the drug targets. Apart from this, central anticholinergics may be used in drug-induced Parkinsonism. They are trihexyphenidyl, procyclidine, and piperidine. So coming to first and foremost, dopamine precursor. So the dopamine precursor is levodopa. So it is one kind of replacement therapy, as because dopamine cannot cross the blood-brain barrier, so this prodrug is given. Dopamine unable to cross the blood-brain barrier, so therefore levodopa is given. So this is an example of a prodrug. Okay, levodopa is converted to dopamine by the action of the enzyme dopa decarboxylase. Okay, and this dopa decarboxylase, it is present in the intestinal mucosa and other peripheral sites. So when this drug levodopa is given orally, then in the intestinal mucosa it is converted into dopamine. So the side effect of the dopamine, like nausea and vomiting and orthostatic hypotension, is there. Apart from this, the bioavailability is also reduced. These two things occurs when levodopa alone is given, because in the peripheral tissues and in the intestinal mucosa, the dopa decarboxylase enzyme is there, which converts levodopa to dopamine, and this dopamine has side effects like nausea and vomiting and orthostatic hypotension. Also there is reduction in the bioavailability. Now 90% of bioavailability is reduced, so it's a huge thing. Therefore, whenever levodopa is given, levodopa is combined with carbidopa. Okay, and in what proportion it is combined? 25 milligram levodopa is given along with 100 milligram carbidopa. Okay, so this combination is given 2 to 3 tablets per day. 2 to 3 tablets are given per day. One thing we need to remember here is 75 milligram of carbidopa per day is generally sufficient to prevent the development of nausea. Now another question is asked usually in the viva, that why levodopa should not be given or should not be taken with high protein diet. And the answer is because the amino acids present in the high protein diet, they compete for the same carrier as levodopa for absorption. Therefore, levodopa should not be taken with high protein diet. Another important thing you have to remember is that pyridoxine should not be used, should not be administered with levodopa. Why? This is because pyridoxine is a cofactor for the enzyme decarboxylase. Therefore, whenever pyridoxine is administered, there is more activity of the enzyme of therefore this levodopa should not be administered with pyridoxine. These two questions are very important. You should remember all the time. Now coming to the adverse effect of levodopa plus carbidopa combination. So first and foremost thing is nausea and vomiting. These are most important complications or side effects. Next is motor complication. In the motor complications, we have two phenomenon. One is wearing off phenomenon, and the second is on and off phenomenon. So first coming to wearing off phenomenon. Now it is initial part of the therapy. The patient is responsive to the treatment. But in the later part, what happens is, as the time passes, the symptoms of Parkinson's disease, they reappear. So there is wearing off of the effect of the drug. So that is why it is known as wearing off phenomenon. Now it is very pertinent to note that the Parkinson's disease is a progressive disease. As because it is a progressive disease, there is irreversible loss of neurons, and there is progression of the disease. So more frequent administration of the drug is required, as well as we need to increase the dose after some time. But this frequent dosing and increase in dose, that will lead to dangerous dyskinesia. Which is very dangerous. And this dyskinesia, what it is? It is painful and involuntary movement. Now the drug of choice for wearing off phenomenon. Two kind of formulations are there which you need to remember. One is called Rytary, and what it is? It is a sustained release form of levodopa plus carbidopa combination, and another is Duopa, DUOPA. What it is? It is a gel combination of levodopa plus carbidopa. And how it is administered? It is administered after gastrostomy. It is directly placed in the jejunum, and this is done through a gastrostomy tube. Okay, so what are the drug of choice for wearing off phenomenon? One is Rytary, which is a sustained release preparation of levo plus carbidopa combination. Another is Duopa, which is a gel combination of levodopa plus carbidopa, which is placed in the jejunum through the gastrostomy tube after gastrostomy. Now coming to the second one, that is on and off phenomena. So in the on and off phenomenon, it occurs in the late PD. In the late Parkinson's disease, the patient, he fluctuates between on episodes and off episodes. In the on episode, there is beneficial effect is on, but there is dyskinesia. Now in the off episodes, there is no beneficial effect. Okay, now coming to the other side effects, that is the third side effect is hallucinations and psychosis. One important point to know is that conventional antipsychotics, they cause worsening of this drug induced psychosis by acting through the D2 receptors. If conventional antipsychotics are given, to treat this psychosis produced by levodopa, there is worsening of psychosis. Why this is there? This is because of action at D2 receptors by the antipsychotics. Okay, so what can be done? You have to treat this. What is the treatment of this L-dopa induced psychosis? So the treatment is by atypical antipsychotics. Atypical antipsychotics, and preferably the two drugs which are given are clozapine and quetiapine. Okay, these two drugs are given. Then the other side effects are worsening of active acid peptic disease, worsening of malignant melanoma. Now why this is worsened? This is because dopamine is a precursor of melanin. The sixth side effect is impulse control disorder, and this impulse control disorder can be due to any dopaminergic agonist. Other side effects are orthostatic hypotension, and it has a potential to cause cardiac arrhythmia. Okay, so these were the adverse effects of levo plus carbidopa combination. So once again, in a short, I am telling it. nausea and vomiting, which is the most important complication. Apart from that, motor complication like wearing off phenomena and on and off phenomena. And what are the drug of choice for wearing off phenomena? It is Rytary and Dopa. And in the on and off episodes, it occurs in the late Parkinson's disease, where the patient fluctuates between on episodes and the off episodes. In the on episode, the beneficial effect is on, but there is dyskinesia, whereas in the off episodes there is no beneficial effect. Hallucination and psychosis. What is the treatment of psychosis caused by levodopa? The treatment is atypical antipsychotics, preferably clozapine and quetiapine. And also there is other side effects like worsening of acid peptic disorders, worsening of malignant melanoma, impulse control disorder, orthostatic hypotension, and cardiac arrhythmia. Another important short question which is asked usually is, what is the rationale behind combination of levodopa and carbidopa? We have discussed earlier that carbidopa is decarboxylase inhibitors. So it inhibits the decarboxylation of levodopa to dopamine in the periphery. So what it does, it increases the T half of L-dopa. So the T half of L-dopa is prolonged and the dose is reduced. Second thing is, the systemic concentration of dopamine is reduced, thereby the side effects like nausea and vomiting is minimized. The cardiac complications are reduced. The pyridoxine reversal of levodopa, it doesn't occur. Then the on-off effect is minimized. And how it is minimized? This is because the cerebral dopamine levels are more sustained. Okay. The degree of improvement in PD with the combination is higher. Some patients who were inadequately responding to levodopa alone also improve. Okay, so these are the points in favor of levo plus carbi combination. That is why it is used. Now coming to the next group of drugs, that is dopaminergic agonist. In this group, there are 5 drugs bromocriptine, pergolide, ropinirole, ramiprexol, and another drug, that is rotigotine. Of this, the bromocriptine and pergolide, these are the old drugs, and the ropinirole and pramipexole and rotigotine, these are the new drugs. And rotigotine is a transdermal formulation. It is transdermally acting. And this ropinirole and pramipexole, these are given orally. So I'll explain these drugs by comparing the older ones and the new ones. The older one, that is the bromocriptine and pergolide, and the newer ones are the ropinirole and pramipexole. Okay, so the T half in the older one is 8 to 24 hours, whereas it is less in the newer drugs. The older drugs are D1 and D2 receptor agonists, whereas the newer drugs, they are the selective D2 and D3 receptor agonists. The older ones are ergot derivatives. That is why digital vasospasm may be produced by these drugs. And these new drugs, they are non-ergot derivatives. Titration period in the older drugs is usually 1 month, whereas in newer drug they can be easily titrated within 1 week. Pergolide of the older drug, it causes cardiac valvular defect. Okay, so these dopamine agonists, they have the psychiatric side effect is more than that of the levodopa. Dopamine agonist versus levo plus carby. So they have a psychiatric side effect more than levodopa, and the potential psychiatric side effects are hallucinations, adverse cognitive functions, impulse discontrol, and apart from this there may be somnolence, that is irresistible sleepiness. And the patient taking this dopamine agonist must be warned of this particular side effect, because road traffic accidents may occur, as because the patient may sleep while driving. Now, what are the benefits with dopamine agonist? benefits are there are no motor complications. That is, there is no wearing off phenomenon and no on and off phenomenon. So, in young patients, we can use the dopamine agonists, whereas in older patients, we have to use levodopa plus carbidopa combination. Now, why in young patients we can use dopamine agonist is quite evident, because the young patients can tolerate the potential side effects of dopamine agonist, whereas the older patients, they cannot tolerate. Older patients, they can't tolerate the side effects of dopamine agonists. Now this ropinirole, it is FDA approved for restless leg syndrome, and this might come as a MCQ. Now coming to another dopamine agonist, that is apomorphine. This apomorphine is a dopamine agonist it is given by subcutaneous injection. It has high affinity for D4 receptors. It has moderate affinity for D2, D3 and D5 receptors, and low affinity for D1 receptor. What is the indication of this apomorphine? The indication is it is a rescue drug for the off episodes where there is no beneficial effect. One of the demerit of this apomorphine is that it is highly emetogenic. And its emetogenic potential is just like that of anti-cancer drugs. That is why it is not used regularly. It is usually given under antiemetic cover. And the usual antiemetic is not 5-HT antagonist like ondansetron and granisetron, as because the apomorphine plus this ondansetron and granisetron leads to hypotension and unconsciousness. Apomorphine plus this ondansetron or granisetron, they lead to hypotension and unconsciousness. So which drug should be used? The treatment of this, the antiemetic cover is cover for apomorphine is a drug called trimethobenzamide. Okay, and this trimethobenzamide, it is given 3 days prior to the start of apomorphine, and it is continued at least for first 2 months, and it should be continued till the drug is used, but it should be continued at least for the first 2 months. Okay, so the other side effects of apomorphine, apart from its emetogenic potential, is prolonged QT interval, and it has a abuse potential. That is, the patient gets a kick out of apomorphine use. Now coming to the other group of drugs, that is COMT inhibitors, catechol O methyl transferase inhibitors, like entacapone and tolcapone. So entacapone has only peripheral action, whereas tolcapone, it has both CNS as well as peripheral action. Levodopa is converted by COMT to the 3-O methyl dopa, and this COMT inhibitors, they inhibit the COMT enzyme, therefore they prolong the T half of this levodopa. Okay, and they are used as an adjunct to levo plus carbi combination. Now this tolcapone, it has got a longer duration of action than entacapone, and it has got another side effect, that is hepatotoxicity, which is not there with entacapone. And what are the side effects that are common to both the entacapone and tolcapone? That is nausea, the same, orthostatic hypotension, then vivid dreams, confusions, and hallucinations. The side effects of both the tolcapone and entacapone, that is COMT inhibitors, are this. Now coming to the another group, that is MAO B inhibitors. So two kinds of isoenzymes oxidize the catecholamine. MAO full form is monoamine oxidase. So the name itself indicates that it will oxidize something. So this MAO, two kinds of MAO are there which will oxidize the catecholamine, that is MAO A and MAO B. Of this, the MAO B is dominant in the stratum, and it is responsible for oxidative metabolism of dopamine in the brain. In the previous lecture, we had discussed that dopamine is converted to 3-methyl-dopa, then it is again converted to homovalenic acid, and this conversion is by MAO-B and aldehyde dehydrogenase. Okay, so what are the MAO-B inhibitors? Selegiline and rasagiline. Okay, so coming to selegiline, first point to remember is it should never be used in late Parkinson's disease. It has mild beneficial effect. And therefore it should be used only in early Parkinson's disease. It is metabolized to amphetamine and methamphetamine, and this amphetamine, it causes insomnia, anorexia and CNS stimulation. It is available as orally disintegrating tablets and transdermal patch. Okay, this is all about selegiline. Now coming to rasagiline. It is a better drug than selegiline, as because there is no production of amphetamine and methamphetamine. Therefore, the side effects that were occurring due to this amphetamine does not occur in rasagiline. Now coming to some of the anticholinergic drugs which are used in Parkinson's disease. The anticholinergic drugs, they may be centrally acting anticholinergics like trihexyphenidyl, piperidine, procyclidine, or antihistaminic like diphenhydramine. Okay, so the mechanism of action is reducing the activity of the cholinergic activity which is increased. And as I have said in the previous lecture, there is always a balance between the dopaminergic activity and cholinergic activity. So if this cholinergic activity is increased, then we have to give this anticholinergics to check this unbalanced cholinergic activity. And what is the use of this anticholinergics? The use is only in the treatment of early PD, early Parkinson's disease, or in the drug induced Parkinsonism. One thing we need to remember is all anticholinergics have to be used cautiously in patients with narrow angle glaucoma. And in general, they are not tolerated well in elderly. Now another drug which is usually used in Parkinson's disease is an antiviral drug that is named amantadine. This is a antiviral drug and it prevents influenza A virus. This has two properties. It has got, for which it is used in Parkinson's disease, it has anticholinergic effect. It blocks the muscarinic receptors in basal ganglia, and it also blocks NMDA glutamate receptors. Its use is initial therapy of Parkinson's disease. It is also used as an adjunct with levodopa in cases of dose related fluctuations and dyskinesia. And what are the side effects of this drug? The side effects of amantadine are insomnia, restlessness, sleep disturbance, anticholinergic effects. And another side effects that is important is libido reticularis libido reticulosis. This is a skin manifestation in which there is mottled appearance, there is grey mottled patches. So this completes all the drugs of Parkinson's disease and Parkinsonism.